Our next speaker is distinguished endocrinologist Dr. Vinod Abichandani, MD MSc in endocrinology from University of South Wales, UK. Dr. Abichandani has served as a principal investigator for phase 3 trials and post-marketing survey involving insulin and cardiovascular drugs. He is an IDF regional faculty member and an editor and reviewer for leading journals including the International Journal of Diabetes in Developing Countries. Today he will speak on MASLD, MASH, endocrinology, expanding territory. Please welcome Dr. Vinod K. Abichandani.
So, honorable chairpersons and all esteemed colleagues, over the next 15 minutes I am going to try my best to go through this complex topic allotted to me by Honorable Dr. Asutosh Misra ji. And I feel handling MASLD and MASH should be a prerogative of all metabolic physicians and endocrinologists and not just gastroenterologists. So I beg to differ from my gastro colleagues. So today I would like to reframe MASLD not as a hepatology problem, but as an endocrine disease with hepatic expression. The shift from NAFLD to MASLD or MASH marks a move from an alcohol exclusion-based, liver-centric definition to a positive diagnosis grounded in metabolic dysfunction. So MASLD now clearly falls within the domain of endocrine practice, and though the terminology has changed, but more importantly, our responsibility has also changed. MASLD, that is metabolic dysfunction associated steatotic liver disease, is primarily driven by insulin resistance, visceral adiposity, dyslipidemia, and chronic low-grade inflammation. All elegant nutrition speakers have alluded to this part of the story, which together lead to hepatic fat accumulation, lipotoxicity, and progressive fibrosis. Because these pathways govern metabolic and hormonal regulation at large in our body, endocrinology plays a central role in the care of MASLD. This includes early risk identification in diabetes and obesity clinics, fibrosis assessment, and the use of disease-modifying therapies such as weight loss at the top of the list, incretin-based agents, SGLT2 inhibitors, and comprehensive cardiometabolic risk management. So MASLD is a silent global epidemic affecting nearly 1 in 3 adults, often progressing unnoticed until advanced liver disease and fibrosis develop. Beyond the liver, MASLD has too many systemic consequences. Manish, can you for a change listen to me please? You are a colleague from Ahmedabad. So MASLD has systemic consequences, markedly increasing the risk of type 2 diabetes, CVD, CKD, and sarcopenia. Importantly, cardiovascular disease rather than cirrhosis represents the primary cause of mortality in individuals with MASLD. MASLD functions thus as a cardiometabolic risk amplifier. MASLD is a chronic liver disease, often reversible, please remember that, caused by metabolic dysfunction such as obesity and diabetes. Over decades, it progresses from simple steatosis to metabolic dysfunction associated steatohepatitis, fibrosis, cirrhosis, and potentially, this is the most sinister progression, hepatocellular carcinoma. The fibrosis stage is the main predictor of mortality. However, cardiovascular disease and cancer are the leading causes of death. So MASLD arises from complex immunometabolic interactions. I think, I don't know whether this is moving. Yeah. So I'm starting here. So MASLD arises from complex immunometabolic interactions involving the gut microbiome, excess nutrients, adipose and metabolic tissues, and the immune system. This interplay causes liver lipotoxicity right in the center, liver lipotoxicity, inflammation, and metabolic imbalance, creating a self-perpetuating cycle that leads to liver damage and systemic cardiometabolic complications. IR, that is insulin resistance, increases free fatty acid delivery to the liver, stimulates de novo lipogenesis, and reduces fat oxidation. At the same time, inflamed visceral adipose tissue and dysfunction of the gut-liver axis, which was also alluded to by previous speakers very elegantly. So gut-liver axis, all these worsen hepatic inflammation. Although steatosis can be reversed, the fibrosis stage remains the most important predictor of prognosis, highlighting the need for early detection to improve clinical outcomes. MASLD should be viewed as a result of interconnected cardiorenal metabolic processes, not merely as a liver disorder. So there is a multi-organ crosstalk going on, and the two slides are dedicated to this particular heading. Hepatic steatoinflammation increases systemic insulin resistance, which contributes to endothelial dysfunction, vascular injury, and worsening renal function. Declining kidney function amplifies the metabolic and inflammatory stress, while myocardial rebonding increases the risk of heart failure with preserved ejection fraction. So together these interactions create a self-reinforcing cycle of adverse systemic metabolic amplification rather than an isolated liver disorder. So again and again I am putting a stress on this, that please don't consider MASLD as just a hepatic disorder. It's a multi-system disease where many other systems are adversely impacted. So MASLD and type 2 diabetes are connected through a bidirectional cycle driven predominantly by insulin resistance. As insulin resistance progresses, it leads to hepatic lipid accumulation and steatoinflammation. In turn, worsening liver dysfunction increases hepatic glucose output and further impairs glycemic control. And this cycle heightens the cardiovascular and renal risk, highlighting the need for integrated multi-system therapeutic approaches. So we need to remember that one thing, in turn proves detrimental to the next organ, and we need to have a multi-pronged approach. So highlighting the need for integrated multi-system therapeutic approaches instead of isolated liver-focused treatment. And a very simple tool that we should all adopt in our clinical practice is the FIB-4 score, which can be easily implemented in day-to-day practice. Fibrosis assessment is central to risk stratification in MASLD, as fibrosis stage is the strongest predictor of not only liver-related but overall mortality. Patients with indeterminate or high scores should receive second-line evaluation using elastography, particularly transient elastography, which is also known as FibroScan, or magnetic resonance elastography, which is very sensitive to pick up liver stiffness and fibrosis. So FibroScan is a practical, widely available tool for large-scale screening for fibrosis in MASLD. Many companies offer this as a complementary service to our day-to-day practice, as well as whenever we organize some camps. So, magnetic resonance elastography is considered the most accurate, non-invasive method for staging liver fibrosis, and there is a further advancements on this that is known as MRI proton density fat fraction. This provides precise and reproducible quantification of hepatic steatosis. So liver biopsy remains the reference standard, but we don't normally go for that. It is reserved, in fact, for cases with diagnostic uncertainty, means there is a dilemma at the end of the day after going through everything else, then we may think of liver biopsy. This stage approach supports early identification of clinically significant fibrosis stage 2 or higher, and enabling timely intervention and targeted cardiometabolic risk management. I have used the term cardiometabolic risk several times because that is the main killer even in patients with MASLD. And such newer things that are emerging include circulating biomarkers such as PRO-C3 and cytokeratin 18 fragments. These are under active investigation for their ability to reflect fibrogenesis and hepatocellular injury. AI, this is the era of artificial intelligence. So AI-driven algorithms are increasingly used in imaging and histologic platforms to enhance the accuracy of fibrosis staging and risk stratification. The three references for these three, sentences are at the bottom. And sustained lifestyle therapy. I think many of the elegant dietitian speakers spoke very well. Sustained weight loss of 7 to 10% leads to significant improvement in hepatic steatosis and necroinflammation, while losses over 10% result in measurable fibrosis regression. And these dose-dependent effects are well documented in interventional studies, including the Look Ahead trial in individuals with type 2 diabetes. Look Ahead was supposed to be a failure initially, but this is a 2024 new paper, and they have done a post hoc analysis and come out with some reassuring data. As a result, structured lifestyle modification is the primary treatment for MASLD. Pharmacologic therapies may be used as adjuncts but do not replace the benefits of substantial and sustained weight loss. And GLP-1 RS provide now a slide or two towards pharmacotherapy. This is where endocrinology becomes transformative. GLP-1 RS provides significant metabolic and hepatic benefits in MASLD and MASH. In the STEP program, the STEP stands for, is the definition, the full form is at the top, semaglutide treatment effect in people with obesity. So in the STEP program, semaglutide, there were 5 trials done under this umbrella term. Semaglutide led to at least 10 to 15% weight loss and substantial reduction in hepatic steatosis. In fact, it has already a FDA approval for use in MASLD. The phase 3 Essence trial of once weekly 2.4 milligram semaglutide showed that 62.9% of participants achieved resolution of steatohepatitis, and another impressive 36.8% achieved improvement in fibrosis at 72 weeks duration. And in the SURMOUNT-1 trial, that is referring to tirzepatide, dual incretin therapy, this product led to weight loss exceeding 20% in many participants, along with marked improvement in terms of reduced liver fat. SGLT2 inhibitors, as shown in the EMPA-REC outcome and DAPA-CKD trials, provide significant cardiovascular and renal protection, modest reductions in hepatic steatosis, and improved metabolic parameters. And the PREVENCE trial demonstrated, this was, please, it's at the bottom, the reference is there, PREVENCE trial design, it had that, non-diabetic patients with non-alcoholic steatohepatitis. So very interesting trial. Demonstrated that pioglitazone improves hepatic histology in patients with biopsy-confirmed metabolic dysfunction associated steatohepatitis. More recently, the Maestro-NASH trial demonstrated significant improvement in fibrosis in individuals with fibrosis stage 2 and 3 diseases, supporting FDA approval of resmetirom, which is a thyroid receptor beta-1 agonist for MASH with fibrosis. So endocrine amplifiers, which are the endocrine conditions which will really worsen MASLD? So endocrine disorders play a key role in the pathobiology of MASLD by affecting insulin resistance and adipose tissue distribution. Hypothyroidism reduces lipid oxidation and increases hepatic fat accumulation. PCOS and growth hormone deficiency worsen insulin resistance, and they also augment visceral adiposity. Menopause and sarcopenia further increase metabolic dysfunction and risk of fibrosis. So together, these hormonal changes highlight that MASLD is a systemic endocrine disorder, not just a liver disease. So MASLD exhibits marked phenotypic heterogeneity across age groups and ethnicities. Lean MASLD, which is very common in our country, common in South Asians and especially in Indians, it reflects high visceral adiposity and metabolic risk despite lower BMI, while pediatric in their teens, 12 to 18 years age group, MASLD represents an unexplained hepatic steatosis in individuals less than 18 years or equal to 18 years of age. In older adults, sarcopenic obesity marked by reduced muscle mass and increased visceral fat worsens insulin resistance and raises the risk of fibrosis. These very clinical. You have a different challenge every time a patient walks into your clinic. So all this varied clinical profiles highlight the importance of individualized risk assessment. I think, Doctor, you just mentioned this point. Every person is a different challenge, and we need to be individualized in our approach. So there is no blanket uniform screening threshold. Try a new trick every time a new patient comes to you. So MASLD significantly contributes to adverse cardiometabolic outcomes. CVD is the leading cause of death in MASLD, even exceeding all liver-related mortality. Patients with MASLD are at increased risk for heart failure, arrhythmias, hypertension, and CKD. These risks are largely driven by cardiometabolic risk factors, this we need to remember, including type 2 diabetes and obesity, and are characterized by shared mechanisms which include insulin resistance, endothelial dysfunction, and some stage of fibrosis. Endocrinologists, what is our mandate? Endocrinologists should take a proactive role in managing MASLD by routinely applying FIP for risk stratification, very easy to adopt in our day-to-day practice, performing early fibrosis staging and initiating intensive insulin resistance treatment. So all treatment should be to combat insulin resistance. Incretin-based therapies should be used strategically given their proven benefits for weight reduction, glycemic control, and hepatic steatosis. So as an endocrine disorder with hepatic manifestations, MASLD requires coordinated cardiometabolic care facilitated by endocrine specialists. Care should be coordinated across cardiology, nephrology, and hepatology. So at the bottom, if more than 5% of the liver is fat, the diagnosis is metabolic. And its stewardship is ours, endocrinologists, diabetologists, and metabolic physicians. So thank you very much for your patient hearing. And if there are any questions, comments, or criticism, everything is welcome.
Sir, there's a large group of people around 5 million. Has anything been studied that the less number of events in there?
Can you repeat the first part? Large number of people on?
Around 5 glitazone.
Pioglitazone, yeah.
So has anything been studied that this retards the whole, theoretically it works, but
Practically, because the dose that was used in all these trials was 45 milligram of pioglitazone. Now, at that dose, none of our Indian patients will be very happy. They will undoubtedly gain some weight. They will have, for example, postmenopausal ladies. We would like to avoid, and such ladies have very high incidence of underlying MASLD. So, my answer is, it has not been proved. It's only a research, very small dedicated research, and the other one, PREVENCE trial, that was in non-diabetic population and with stage fibrosis. So biopsy-driven use of pioglitazone was, done, and in day-to-day practice, I don't think we will be inching up to that mega dose because we have better options. You give simple empagliflozin or dapagliflozin, they are good. You have GLP-1 incretin-based therapies. They are expensive, but they are very good. In fact, semaglutide has now, got a official approval from FDA for use in MASLD various stages. So, thank you. Yeah. Excellent, excellent. I totally agree with you. Can I?
Why I brought down Saraglitazar is that when the person who invented Saraglitazar came, he said, all you need is a touch of PPR gamma effect. You don't need to really give the entire dose for it to be effective. So, in a lower dose, would 5 glitazone?
No, pioglitazone, no. I'm very big no. And regarding saroglitazar, I thought I misheard, though I have not put it on the screen because there is no DCGI approval so far for MASLD, but it's another excellent tool, local research. Okay. Yes, Dr. Manish? Yeah.
First of all, thank you for the nice and lucid talk, because fatty liver and MAS is a very budding issue. We are seeing of the thin fat Indian, particular the sarcopenic obesity, it is what. I agree with I did the study of the saroglitazone. I have put the more than 150%. And I'm getting very good result who are diabetic, apart from the HbA1c reduction of the 0.4 to 0.5%, TAG is getting the down, and even the fatty liver and about of mass is improved with it will take of the couple of the years with it is definitely it is a costlier drugs, 40 to 45 rupees of the per day. But I am happy with this particular saroglitazone is a very good of this particular and even I presented in the case in Boston in the ADA,
right,
and along with Dr. Sasank, Dr. Ashok Jaiswal and Ahmed Thakkar. And
so Ashok Jaiswal is the Riders medical
I did the study at least for the first time.
Right.
I am a principal investigator of the
saroglitazone.
That was it. And some of the theory of the patients are coming with the vitamin E. Some of the company they are coming with the 5,000 international of the vitamin E is helpful. Of this particular, the 5,000 international, because of vitamin E can cause hemorrhagic stroke, and some of the cystitis can be occurring.
So the pleiotropic, hazardous side effects are going to say, I would
But
be
why the
discouraged
most of the
in
company is coming
recommending
with
that.
the vitamin E, the 5,000 international per day is too high dose of that.
I think
This
all of them
particular,
have been,
some of the,
you
my
know, they've
gastro
been
friends,
tried and rejected.
some
So
of
these
my
are all
gastro,
like
well-known gastro
placebo
friends, they are
if you
writing the
use,
vitamin E.
or maybe as an adjunct therapy you can use. Otherwise, regarding saroglitaz, or you have done 150 patients and presented at Boston, but 4 milligram standard dose once a day. Primarily in 2013, it was ushered in to address triglycerides.
Triglyceride.
Then they realized that it's also benefiting ultrasonologically the fatty liver. You know, in those days we were using only NAFLD, the new terms arrived 3 years ago. And now we also have a term MAT-ALD, that is metabolic dysfunction associated alcoholic liver disease, which is a new entity, you know, identified last year. So thank you for sharing your vast experience.
Thank you, sir, for nice and lucid talk.
Thank you.
And any
Yes,
professor,
madam.
any take-home message?
ICMR has come up with a study where they put that the childhood obesity, the children who are obese,
Yeah.
they were having non-alcohol fatty liver because
Right.
at that time it was ANLD.
Yeah.
So they have come up with an answer that after 10 years, they will develop diabetes, or within the 10-15 years of span, they are developing diabetes, and then we should start talking about childhood obesity. So that's why childhood obesity is on the peak right now.
Right.
I want to know, sir, because earlier it was non-alcohol fatty liver. So should we start screening kids for this also?
Yes.
Because
So, I mean, that's a very important point raised, and I think we recommend, in my humble practice, even age group 11 to 18. If I feel they are overweight, they are all sedentary, they are all the time hooked to the snacks and to their, you know, their mobile phones and all games, I do screen them. So, and then we go even in the reverse manner. First, we have screened the kids and then screened their parents and the family tree and found out, yes, sir, please.
thank you so much, sir. Thank you.
Thank you. Not 6 to 7 years, I agree. Sir को दो ना सर को हाँ सर
That is the time according to ESD.
that we should be screening. I
Yes.
agree. But
All-
you see, बहुत छोटे बच्चे को अगर वो जैसे सेंट्रली ओबीज नहीं है या चबी ज़्यादा नहीं है, फिर उसके मम्मी पापा को बोलो कि चलो ये 7 साल का है, इसका मैं लिवर देखूं, they might get alarmed. So even if I do it very
You can't
softly.
help it.
I mean,
You
tell them.
can't help it. You should focus on medical problems rather than what patients.
Yeah, I understand. I mean, technically, your advice is 100% golden, sir. That we should be starting it even earlier. This is a takeaway for you and me, both of us. That not 11 years, we can start at 7 years, 6 years. And especially in mothers who have had, you know, history of GDM, then definitely start at screening for all sorts of metabolic disorders, dyslipidemia, high triglycerides, fatty livers, at a very younger age, relatively younger age, maybe 6 to 7. Yes, sir.
A masterly talk, as always, you have delivered. Sir, but the thing is that he has rightly mentioned, most of the school surveys, they show around 60% of the kids are
yeah, having
in
some degree
obesity
of
or
fatty liver.
obesity.
Yeah.
So definitely we should start acting on them. Thank you, sir.
Yeah, it's a very important point, and a takeaway for all of us, including me, be more vigilant, then be more pharmacovigilant, screen them, and stem the rot very early. Thank you very much. Thank you.
Thank you. Thank you so much, sir. I would like to extend our heartfelt gratitude for such an intellectually stimulating session. On the behalf of organizing committee, I would like to express our deepest gratitude to our chairperson for his masterful guidance of this session. Thank you so much, sir.